All right, everybody, this is going to be part one of Chapter 8, Language and Students with Intellectual Disabilities. We're going to explain the definition and causes of intellectual disabilities. In this one, we're going to start describing the specific language and communication characteristics of children with intellectual disabilities. We'll do that here with Down syndrome, factors related to language development and the impact of language on the literacy skills of individuals with intellectual disabilities. And we're going to discuss methods for enhancing the language and communication skills of individuals with intellectual disabilities. All right, so we're going to go here to an article that talks about the diagnosis and assessment of people with intellectual disabilities, but it's really talking about here the definition. So historically, intellectual disability has been defined by cognitive deficits established through a standardized measure of intelligence, in particular with an IQ score below 70, and also by significant deficits in functional and adaptive skills. So adaptive skills are going to involve the ability to carry out age-appropriate daily life activities, and two different ways for classifying ID used in the U.S. are through the American Association on Intellectual and Developmental Disabilities and the DSM-5 are the two biggies. Okay. So, intellectual disability is a disability characterized by significant limitations both in intellectual functioning and in adaptive behavior, which covers many everyday social and pragmatic skills. This disability must originate before the age of 18. Individuals who score below an IQ of 75 can be considered intellectually disabled according to your book, right? But really that number should be 70. So I guess either would be right, but I think officially it's going to be a score of below 70. We must also score below the norm on an assessment of adaptive behavior. And adaptive behavior is going to consist of conceptual skills, social skills, and practical skills. Conceptual skills are going to be skills including language and literacy, math concepts such as money and time, self-direction. Social skills are going to include interpersonal skills, social problem solving, and the ability to follow rules and obey laws. And practical skills are going to include activities of daily living, such as personal care, occupational skills, being able to use transportation, and the use of the phone. So here we've got activities of daily living are going to be made of feeding, continence, transferring, toileting, dressing, and bathing. Remember, we talked about that transferring is really just being able to move from your bed to a chair, to the bathroom, to get on the toilet, to get in the shower, and back, right? So just being able to move around and do and meet your very basic needs. And then we've also got instrumental activities of daily living, which is using the telephone, shopping, preparing food, housekeeping, laundry, using transportation, handling your own medications, and your own finances. We can look at mild, moderate, and severe, and profound. Right, the vast majority of people with a cognitive impairment, just like the vast majority of all disorders out there, most people are going to be mild. So about 85% of people are going to be mild. Their IQ will range between 50 and 69. And they are able to live independently with just minimum support. People checking in on them, making sure they're okay. But they're able to live on their own to a great extent. Another 10% are going to be moderate, an IQ range between 36 and 49. People can still live on their own, but they're going to need more support. They're going to have to live in a group home, so they'll be able to have their own room, their own space, but they're going to need, more constant support, living in the same building with them. Once we get to severe and then profound, these are going to be people that require much more assistance, aren't going to be able to live on their own, or else they'll really, the chances of them hurting themselves, not being able to take care of themselves, are going to be really, really high. Okay. Some causes of ID. Genetic conditions, so people with Down syndrome, Fragile X, Williams syndrome, problems during pregnancy, alcohol and drug use are going to be one cause. Problems happening at birth, children with low birth weight, and asphyxia, loss of oxygen, are going to be more likely to have intellectual disabilities. Problems after birth, head injuries, lead or mercury poisoning, or childhood diseases like measles and chickenpox that can lead to complications like meningitis and encephalitis, which can cause cognitive impairments, and then poverty and nutrition. So higher risk of malnutrition, people with poor medical care, people with exposure to environmental hazards, all are going to be more likely to end up with cognitive impairment, right? So let's talk a little bit about people with Down syndrome, sometimes called trisomy 21. This is going to be about 1 in 1,000 births, and these individuals have an extra copy of chromosome 21, so they've got 47 chromosomes because they've got 3 chromosome 21s rather than 2 of them, so they've got 47 total in each cell rather than 46. On average, they're going to be smaller than the average person. They're going to be slower physically and mentally in their development. They're going to have flattened back of head, slanting of eyelids, smaller ears and mouth, narrow palate, right? That's going to lead to hearing disorders and speech disorders. So the majority, again, just like we talked about, the majority of people with Down syndrome are going to be in the mild to moderate range, but there's a really wide variation on mental abilities, overall skills and abilities, what people are able to do and not do. So just from an early language development standpoint, young children have been reported to use the same sort of nonverbal communication as other infants. So smiling, laughing, reaching. However, they're going to be much less likely to use vocalizations with their gestures, and the vocalizations are going to come later than your typical child. The use of gestures may be a strength in babies with Down syndrome. So even though they're not vocalizing, they really are going to gesture to what they need. Again, the vocalizations are usually going to come late. That's going to go along with usually a delay in the onset of babbling, but not all the time. Once they start babbling, they're going to continue to babble longer than their typically developing peers, often continuing to babble into age 2. It's important to remember, though, that your average child, even though they're going to say their first word at 12 months, they're still often going to babble along with words. So you'll have babble, 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 word, babble, 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 and then, it might be 14 months, 16 months before the babbling really goes away, and they've got pretty much just words if you're, your average typical child. The acquisition of first words in people with Down syndrome is going to be significantly delayed. And these early language delays are going to continue as the child develops, causing the gap between them and their peers to widen. So the older the child with Down syndrome gets, the farther behind the typical average kid they're going to be. These kids are going to be more likely to have speech and sound disorders, difficulties in the domains of voice, speech, sound production. They're going to be more likely to stutter, have prosody issues, and have intelligibility, being harder to understand. Difficulties are going to be caused by lots of factors. right? We talked about the anatomical difficulties, right? If you've got a smaller smaller palate, that's going to make it harder to speak and move your tongue around, right? So the vocal tract, the tongue, facial muscles are all different. Impaired hearing, ears are going to be smaller. They're going to be more likely to have otitis media, which is going to cause them to have a hard time hearing. They've got impaired motor functioning, which if that's a pretty holistic impaired motor functioning, that's going to impact their speech motor abilities. And we're going to have central processing disorders that affect language and cognitive functioning. We've got delays and differences in phonological development are also frequently found. The most common phonological errors are reduction of consonant clusters and final consonant deletion. It's really that final consonant deletion is going to really impact intelligibility. So we want to really work with these individuals to help them learn to put endings on their words, and that's going to really help their intelligibility. As they grow older, the lag in phonological development increases and the error patterns persist, even when compared to typically developing younger children matched for mental age. So even if you're going by, where kids are cognitively and intellectually, those sort of younger typical kids, their speech overall is probably going to be a little bit better than people with Down syndrome. Morphology and syntax, we've got significant delays in morphology and syntax. However, the pattern of development is going to be really similar to the average child. Syntactic delays are going to begin as soon as they make the transition from single to multi-word utterances, right? Because you can't really have syntax if you're at the one-word level. There is no grammar. It's just individual words. So, as soon as we got multi-word utterances, the syntactic delays are going to show up. Their MLU is going to be significantly shorter than their peers. Short, less complicated sentences. Semantics. The first words are going to be late. One study has found that children with Down syndrome performed better on the vocabulary comprehension task than on tests of syntactic skills. So their semantics and vocabulary is going to be a little bit better than their syntax. Other studies, however, have shown that language produced in natural settings indicates that these kids are going to have a more diverse vocabulary than do typically developing children matched for mental age. And that makes sense, right? That if you have a 12-year-old who has Down syndrome and they have the language age of, let's say, a 6-year-old, well, that 12-year-old with Down syndrome is going to be with a lot of other 12-year-olds now, thank goodness. So even though they've got the language skills of a typical 6-year-old, they're going to use different vocabulary words that their 12-year-old peers are using. So they're going to have, vocabulary words that the average 6-year-old does not have, even though their language abilities are at the age 6. So they kind of have some cool semantic skills going on. Pragmatics, conversational turn-taking is not affected. However, people with ID usually don't make significant contributions to maintaining the conversation. So they're able to take turns, but if you stop your turn, they're not going to keep going on their own, right? They kind of need that conversational partner to take the lead in this. So they don't really extend the conversation by adding new information. People with Down syndrome may have a delay in comprehending speech, but they may have strengths in understanding the messages that others are trying to convey. So even though they might have a harder time just with the speech aspect and understanding speech. They're often able to pick up clues from a pragmatic standpoint and figure out what you're telling them, even if they don't quite understand all the words. Children and adolescents with Down syndrome may use less polite forms of speech, so they'll often just be more direct, right? Instead of pleases and thank yous and things like that, they'll just say, I want this, I want that, I need this, I need that. But again, still being able to get their message across, right? Being polite, you still certainly get your message across. Referential communication tasks, in which children are evaluated on their ability to explain a task to another person, may be difficult for children with Down syndrome. Again, and this kind of goes back to what we said before, they're going to give fewer descriptions to their partners, leaving it up to them to request more information. So, right, they're going to have a hard time explaining something and maybe telling a story too, unless their conversational partner prompts them in what they need. And we are going to stop here for part 1.